edition, in where we are going to be speaking about genetic therapies in HCM, specifically MYBPC3 mutation. And we are going to be hearing from a clinician, a patient, and in the second segment, we'll be hearing from industry. But before we begin that topic and that conversation, I have a few announcements and just 2 slides that I wanted to bring up. Number one, we are just days away from our official 30th anniversary. HCMA received its 501c3 status in February of 1996. So in a couple of days, we hit our official 30th year of operation. And later in the month, on February 25th, we'll be celebrating HCM Awareness Day. If you would like to get a circular frame picture done for your social media presence, you can just email a photo over to our office and we will be able to put that frame on for you. Jimmy, can I have the next slide, please? And, oh, not that one, that one. Thank you. And we have something new this year. We only have a small quantity. We are having an HCM Awareness Day kit sent out to each one of our centers of excellence. So each of them will be able to have these materials in their office. But we have a couple of extra kits here in the office. We've got about 30 of them right now. And if you are interested in this kit, which is the posters behind me here in my office, which serve as photo walls that you can put up in your place of work, play, school, church, wherever. And we have new HCMA wristbands and a couple of other materials like a little no HCM pop-up where people can get additional information. So if you are interested in getting one of these kits, please contact the office at support@4hcm.org and say, I'd like one. And they will tell you what the process is and we'll get that out to you. This is the first year we're doing this. If it goes over well and you like it, we'll go bigger next year, but this is our first time doing this. So that is all I have to say about the announcements. And now I am bringing to the stage Dr. Melinda Tsai from the Cleveland Clinic and Julia, a patient with HCM. Welcome to both of you, and thank you for joining us on Tales from the Heart.
Thank you for having me here.
So I'm going to start with Melinda for just a minute. So a clinical trial company approaches you with a concept of gene therapy for MYBPC3. It's cutting edge, it's new. What made you as a clinician interested in participating as a PI in this particular project?
I think, it is the need to push the envelope forward and not accepting the status quo. You've known me for a long time. I am definitely not about accepting the status quo, and I want to push the envelope forward. And look, I think you know this also. One of my best friends died from this exact disease, this exact genetic mutation. So every time I step into a patient's room with HCM or anything else, I walk in with that, I need to be doing everything I want to for that particular patient. So this was essentially a no-brainer for me. Once I understood the concept, I wanted to understand more. And once I delved deep into it, then, it made perfect sense for me.
Fantastic. We're going to hear about the science in the second segment here. We're going to keep this kind of separate from the physician-patient experience and then the actual study. So we will be getting into that later if you're just joining us now. Okay, Julia, we saw a headline about 2.5 years ago. 27-year-old woman is the first to be dosed with MYBPC3 AAV9 therapy. And I didn't know who you were at that time, but we knew each other through, HCMA. And then we met in person in November when you outed yourself as being patient 1. And I was excited to hear your why. So can you tell our listeners a little bit about your family history, and then we'll get into the why you stepped forward for this particular study?
Sure. So my name is Julia. I'm from Canada. As you can see, lots of snow behind me. And I have a pretty strong family history. My mom, unfortunately, passed away at 42 of the same disease. And then her father and then my great-grandfather. So 4 generations of all in their late 30s, early 40s. And then I had a late diagnosis. I didn't understand why I felt the way I did, despite my family history, believe it or not. And then when I found out, I looked for other answers. I obviously had a myectomy. And yeah, that's a little bit about my family history.
So you hear about a genetic therapy clinical trial. How did you hear about it?
Google, actually. My local cardiologist, I went to him after my myectomy and said, look, I want kids, but I don't know if I want kids, if there's a good chance I'm going to end up like my family. And he said, oh, there's things coming down the pipeline. Like, you never know. There's a thing called genetic therapy. And so I'm in Canada. It wasn't something that we offered here, but I went online and onto Google, and the clinical trial showed up, and they were accepting patients. At the time, I didn't know that I would be patient number one, but I was still interested.
So patient number one,
Yeah.
that comes with a bit more risk than patient number 2 or 3 or 4. And I'd like to hear a little bit about your risk benefit balancing act in your own mind, and how you got through that process.
Yeah, so it was a long couple of months leading up to the ultimate decision, but there's a lot of back and forth. I think the big factors were that it was done in a center that I had recognized even as a Canadian, the Cleveland Clinic, and I trusted that that was one of the best places in the world, especially for heart disease. And then I researched the company, and also the information that I had about the animal studies that they did with the gene therapy looked extremely promising to me. I mean, I'm just a lay person. I don't really know everything, but it was incredible what they were doing in the animal models. And then also, I think the fact that there are approved gene therapies in the market, like hemophilia being one of them, and then there's other ones down the pipeline. I just think the combination of those things were my risk benefit, including the fact that because I am Canadian, I knew how long drug processes take to approve. So I think being patient one, I felt like that was my chance at an AAV9 in my lifetime. I'm 30. Like I said, about my family history, all dying around 40. So the cost risk benefit was just, this may be my only shot, and the people behind it seemed knowledgeable, and I just thought I made the best decision I could at the time.
Lisa, I will tell you, I have very, very vivid memory of the first time I met Julia in person.
I bet you do.
Yeah, I mean, look, there are certain things you don't forget, right? This is clearly one of them. I mean, with regards to Julia, the first time we met in the office and the first moment the drug was getting infused, I will never forget it till as long as I live. No question. So, the poignant questions that she asked, specifically, she mentioned about the big animal model. I will admit, I'm not a big animal modelologist. Okay, I'm just a simple cardiologist. So, I knew about the literature, but I did not. I think on the first meeting, Julia knew more about it than I did. I'll be very frank. I knew the bigger. So, and if you recall, I do. I'm like, I will read up on it and we will get back to you. There was a specific question she asked, and I said, I will defer answering that question till later. So that is one thing that impressed me the most about Julia on that first meeting. And on the day of the infusion, I remember we were on the 8th floor here, and as the infusion started, all three of us, me, Julia, and Danielle, we were looking at each other. Danielle was the nurse who did the infusion, and we were looking at each other, trying to just stay calm. My heart rate, I think, was about 130 or something like that, and so was everybody else's. But, brave girl, but, there's more than bravery. There's bravado, but there's also
Logic.
Absolutely.
Yeah. And, this is what we're going to be discussing in April when we go to the FDA with a patient-focused drug development meeting, with the conversation of What do we do about gene-based therapies? How do we develop them? What is the risk tolerance of the patient community? What does the science say? How do we marry them both together? Now, not everybody would make the same decision as Julia did. And not everybody has the same circumstances as Julia has. And each person has to evaluate what's important to them now versus what might be available to them later. And it's a really hard, it's almost like a transplant in the decision making. Like, this is a big one. Myectomies, big one. Defibrillator, big one. But transplant and gene therapy, like a magnitude greater. It's not something you can undo. You can't stop a drug. It's a forever thing.
Mhm.
So it has been 2.5 years, or 2 years and 3 months or so, 4 months. Without, and I'm being very careful here with what I'm going to ask, because we don't have outcomes data. We don't know anything about the rest of the cohort other than what's been published. And we're going to hear a little bit about that later. But just generally, how are you feeling, Julia?
Good. Generally good. I mean, I'm a human. I think we all have good days and bad days, and I think that's to be expected. And you know, life is stressful, but I feel good. I feel like I look healthy. I feel like I don't regret my decision to do the gene therapy, and I'm taking it day by day, and fingers crossed, because who knows what the impact will have for me. Everyone thinks about the maybe effects that are negative, but we don't know what the positive effects are going to be in the future as well.
Did you have any negative effects from your infusion or in that period right after your infusion?
I think being the first person, it was very stressful. It was a lot of what ifs. And so that whole year was, I think everyone was just on their toes. So I think dealing with the stress was something that I had to learn how to manage. But I think now, specifically, like, I'm moved on in my life. Not moved on. This is still something I'm participating in, being here, and I'm happy to talk about it. But I'm like a nursing student now and managing well with that. And so I think after the stress had left, it felt like I was right back in my normal life. And I'm happy. I'm healthy. That's kind of how I feel about that.
Lisa,
Lynn, from your point of view, was there anything that made you get that heart rate up a little faster during that infusion and post-infusion time?
Absolutely. Look, I will give you a perspective. She was infused on a Tuesday. The HCM Society scientific session was in Cleveland on Friday.
I know, I was on an airplane while all this was happening.
Exactly. And on Monday night, after a full clinic day, for the infusion, I had slept 2 hours. 2 hours. Julia, you didn't know about that. 2 hours. And I was working on Fuse. At the session, I was fairly sleepy. But, you know, there's one additional thing. For 2 months after the infusion, I did not turn my phone off, including an international trip where, you know, I was so paranoid about not losing connectivity that there was a period of time that I lost connectivity flying over North Pole, and I was so anxious at that time. You have no idea. But you know, look, we were also learning. Okay, this was sort of, you know, what I told Julia is she was sort of the Neil Armstrong equivalent, right? The first person, and we are here. She's the one. If there is a side effect, if there is something going sideways, it was going to be her. We were there to back her up, but it was her most definitely. And look, at the end of the day, I have a daughter that's not significantly younger than Julia. Okay, so there's that element of responsibility that goes along with all this, and you know, but there was no turning back. There was no turning back. We were committed to doing this. We had all, and the big thing is, Julia mentioned, look, I'm blessed to be working where I'm working in the Cleveland Clinic. This is, you know, I knew an important part was there was a total team support. Okay, we had all the backup teams, and
Can you
one
talk
thing.
a little bit about what a backup team looks like for gene therapy infusion?
So we had to secure, no questions asked, a quiet room, a good room. Julia had a very nice room, the queen's room, or whatever we call that, literally and figuratively. But more importantly, little things. The nursing staff had to be trained. We had to get a specific IV pole, the pediatric infusion pump, etc. We had to discuss with the pharmacy folks about the logistics of it. Echo standby. My colleagues in immunosuppression, so heart failure transplant colleagues were on standby. Liver was on standby if something goes south. So, and I can go on and on and on. But one thing, every infusion I've done so far, 4, right? The morning of the infusion, I walk my boss, I report to the chief of Heart Vascular Thoracic Institute, Lars Svensson. He knows what we are doing on the day off, every one of them, so that, and there was full support. It's not just the patient. I also want to make sure that I have the backup of the team. And then, the research nurses, Danielle, I mentioned, the rest of the support staff, my nurse practitioner, Sue Ospina. I mean, we work together as a team here. And look, we can look back, reflect on it, but this is one of those till Neil Armstrong lands on the moon and returns safely back to Earth, everybody should be on edge, rightly so.
So we have a comment. We had one from Tim saying Nova Scotians are tough. And now we have a thank you from Jennifer. We truly, Julia, appreciate the pioneers. It takes thought, logic, and bravery, and I think in that order, to make the decision that you made. And you may not have a benefit from it, and you may have a benefit from it. We hope that you do. We thank you for taking the risk on behalf of the community and coming out to speak publicly about it. I know when we originally spoke, it was important to you as a woman to step forward in research, as women have traditionally been underserved in the research community. And in this case, you're like, no, we're going to start with the girls on this one. And for that, I applaud you. So what do you have to say to other people considering being involved in a clinical trial in general, and specifically a genetic one?
I think that if you are in a position where you are able to, but not just physically and maybe financially, but also mentally, because there are some mental hurdles you have to go through, then I think you should definitely talk to your cardiologist and get some opinions and see if a clinical trial is right for you. But as much as there's risks, there's also the potential of benefit. And you're very lucky in the United States to have great, and in Canada, and all over the world now, great HCMA centers, thanks to Lisa and the HCMA. So yeah, if it's something that you are interested in doing, I'm alive, and I think that if you want to do something like this, it's cool. It's scary, but it's cool. Yeah.
I have to tell you, Lisa, one thing I forgot in the other vivid memory. This is in a follow-up a few months down the road. I get a text from my coordinator because she was just relaying the message from Julia. Julia's question to her was, can I go snowboarding? I'm like, how millennial of you, or Gen Z of you, whatever that is. That day, my heart rate went up. I mean, I thought about it for a little bit, and then I'm like, just go on a PG-13 slope or something like that. That's what I said.
No black diamonds. No black diamonds.
No black diamonds.
So, Julia, you're living an active life. You're a student, and we understand damn close to a 4.0 at your studies there. So congratulations.
Thank you.
You're living your best life, and we're going to bring you back from time to time to check on your journey. This is our second time to have an opportunity to talk. So maybe in a couple of months, we'll bring you back. So if anybody has other questions, we can discuss that later. I'll answer that question later. Oh, that's a nice one. To send thank you notes to our providers to remind them how grateful we are for being there. And, as you brought that up, not really related to this topic, but in general, as healthcare goes through its challenges that we're all experiencing now, I think it's incredibly important for us to realize that we only have access to healthcare through the people who work in healthcare. And we are all facing challenges and we all got to work together. So saying thank you and expressing a little kindness in the world might go a long way these days because it's a little rough out there. Okay, Julia, we look forward to having you back again, and we're going to say thank you, and we're going to put you out of the main stage here, and we thank you for your time and look forward to talking to you again. We're going to keep Dr. Desai up here.
Thank you.
Julia,
Bye.
thanks.
Julia, good to see you again.
Yeah, you too.
Best of luck in your school. Yeah.
Okay, so now we're going to do like an official flip here, and we're going to bring Whit Tingley, who is a representative from Tenaya, to the stage, which means I have to scroll down and find Whit, and there is Dr. Whit Tingley. Hello, Whit. Welcome to the front stage.
Thank you. Thank you for having
Again.
me.
So we're going to, Whit, why don't you tell everybody a little bit about who you are and who Tenaya is, and then I'll bring your slides up and we'll start talking.
Yeah, I'm Whit Tingley. I'm the Chief Medical Officer at Tenaya Therapeutics and a cardiologist. And we spent many years working on gene therapy in the lab to treat genetic cardiomyopathies, including this particular gene therapy for hypertrophic cardiomyopathy. If you want to just go to the next slide, our mission is to discover, develop, and deliver potentially curative therapies targeting the underlying cause of heart disease. But we can't do it without patients and without doctors like Dr. Desai. Listening to the prior section with Julia, certainly inspirational and reminds us all that all the life-saving treatments and therapies and surgeries that many of us and our family members have received, there was always a first patient. These were all developed deliberately using science, but with patients willing to participate early to help improve care, not only for themselves, but also to benefit all the other patients coming after them. So at Tenaya, we have 2 active gene therapy studies now, one for hypertrophic cardiomyopathy and one for arrhythmogenic right ventricular cardiomyopathy, or ARVC. We're also conducting 2 observational studies, no treatment, but to learn more about the natural history of these particular diseases related to these 2 genes. And we are very active in patient advocacy. We have a patient advisory council that reviews our protocols, our consent forms, other patient-facing material, lets us know when we're being unintelligible and so forth, or what else we need to be saying. We also have websites that anyone can go and learn more about the disease and what we're doing at hcmstudies.com and arvcstudies.com. And please reach out directly to us if you have questions or certainly interest in the clinical trials at patient.advocacy@tenayathera.com. So this is the summary, the take-home messages for our clinical trial in hypertrophic cardiomyopathy, where Julia was the first patient enrolled. Six additional brave and dedicated patients have joined her at this point in the trial. And we're very happy to say that the gene therapy itself, which we call TN-201, has been well tolerated at both doses. Part of the reason that Julia was so brave and all these patients are so brave is there can be unexpected things that happen when we try something new. And fortunately, we have not run into any unexpected events. Everything has been sort of typical of prior gene therapies, including the approved gene therapies, as Julia mentioned. As part of the study, we do heart biopsies, little snippets of the heart. These are routine. People like Lisa who've had a heart transplant are very familiar with these. They're standard of care there. Anyway, we use those biopsies to make sure that gene therapy is doing what it should be doing. It's delivering DNA to the heart. The DNA is then making RNA and protein. If we have time later today, we can go more in depth about that. But high level, very encouraging results. It's doing what it's supposed to do. We do use immunosuppression. The immune system does react to the gene therapy, and we need to prevent that. So when Lisa compares it, this therapy to a transplant, that is a similarity, but a big difference is that the immunosuppression here is temporary. And in learnings from our trial, we've been able to reduce the total amount of immunosuppression used. Most importantly, the patients are feeling better. We'll talk about the data, but the New York Heart Association classification of heart failure symptoms has been improving across the board. We're also taking pictures of the heart and blood tests to look at the heart size, structure, strain, and we're seeing some early signs of improvement there as well. So overall, encouraging safety, encouraging signs of efficacy. We need to learn a lot more to know if this is truly working or not, as Lisa, you said in the prior segment. But we are well on our way. And again, couldn't be more thankful for the patients who are participating, as well as the doctors. And the staff, as Dr. Desai said, so many people.
There's a lot of people involved in that dosing and the preparing, and later on, I hope we get a little bit more into patient selection. So we'll talk a little bit about that later. This is a little bit on the ARVC. Why don't we cover this real quick?
I'll just say that we do have another trial going on in another genetic cardiomyopathy. There are many similarities. The diseases are very different. The genes are different, but the way we deliver the gene therapy and assess it is very similar. So we are sharing learnings across both trials, and we have encouraging early data from this trial as well.
I'll pause here to explain to the community. We haven't published a lot of this. You might have heard me talk about it on other podcasts. HCMA is leading a coalition of organizations in a patient-focused drug development meeting with the FDA on April 23rd. And we are specifically, we could be very HCM specific and go to the FDA and just talk about HCM gene therapies, but we share so many learnings between what's going on with the Dannon's disease protocol with an AAV9 delivery. And there's work going on with a different type of gene therapy for different disorders like Friedreich's ataxia and amyloidosis and HCM and DCM and ARVC. But we are all focusing on the heart muscle and its function. So we came together as a coalition to discuss it more broadly with the FDA and hear the patient burden stories, as well as our hopes for the future and our willingness to participate in certain designs of clinical trials. So stay tuned for more information on that. But it kind of explains why you're at an HCMA event hearing about ARVC, because they're our friends. Next slide, sorry.
So we will go deeper now into the trial for HCM, and this is a trial specifically for patients with hypertrophic cardiomyopathy due to mutations in this gene. Awkward to say, but MYBPC3 is the name of the gene.
My gene.
Indeed. I'm sure the audience, you all know a lot about hypertrophic cardiomyopathy, a disease where there's too much heart muscle, can be stiff and hard to fill and prevent good cardiac output blood flow. Also, it can get so thick it gets in its own way and becomes the obstructive form of hypertrophic cardiomyopathy. So in many families, this disease is caused by gene mutations, and the most common genes all have the same theme. They're all involved in the actual contraction apparatus, the proteins in the heart muscle cells that cause contraction. MYBPC3 is the most common genetic cause of hypertrophic cardiomyopathy, and it is directly involved in regulating the proteins that cause the contraction. And without it, the heart becomes stiff and inflexible. Now, the way that the variants or mutations in the genes act is they cause loss of function. So the gene can no longer make the critical protein. So gene therapy on its face is quite simple. We're just delivering a new gene. So replacing the broken gene with the new one. And to do that, we use a capsid based on a prior virus. This one capsid is called AAV9, and we put the new gene in there. The capsid can deliver that gene to the heart muscle cells and allow the production of the MYBPC3 protein. And so this trial is directly testing that therapy. It's delivered once, as was discussed before, as an intravenous infusion, and it can only be delivered once, because once the immune system has seen it, it develops a way to block it the next time.
Okay.
So the main objective of this trial is safety and tolerability, and we are testing 2 doses. And at the end, when we put all the data together, we'll determine which dose is safer and more effective. As we talk about early results today, we'll be talking primarily about the first dose that we tested. For a patient, it starts with informed consent. So Julie and Dr. Desai said they spent weeks kind of discussing the trial, the potential benefits, the potential risks, and the logistics, all the trial visits and making sure it would fit into Julia's lifestyle. Then there's a period of screening where we test lab tests and pictures of the heart to make sure that the patient meets all the criteria to participate in the trial. And then if they do, they are enrolled, and there are pre-dose activities, including initiation of that prophylactic immunosuppression regimen to quiet down the immune system reaction. Then there's the all-important infusion. And then there's a brief period of hospitalization for very close monitoring after the infusion. That's 7 days or so. And then fairly frequent visits during that first year. But after that, the burden of the trial is substantially lower for patients, with visits every 6 months to every year after that, for a total of 5 years.
One thing, can I make a comment here
Please.
as it goes on? This sounds daunting, right? The visits and this and that. But let me tell you, in my experience, out of the 4 people that we have taken care of here, I mean, having an upfront conversation about what is expected goes a long way. And ironically, Julia lives the closest to Cleveland Clinic. I'm not making it up. I just checked the miles. Julia lives the closest to the Cleveland Clinic. The rest of the 3 people are much further away from here.
She lives in another country, technically. So, yeah.
And she lives in another country. So, that just tells you Cleveland is too far north, unfortunately.
Yeah, absolutely. So for our trial sites, Cleveland Clinic, first and foremost, we are developing centers and using centers of excellence for gene therapies. So we don't have many trial centers, but we have the most expert trial centers, and that does mean traveling for the patients that participate. That travel, all the expenses and local housing is all covered for participants in the trial.
And a family member?
I believe so as well, yes.
Yeah, I believe that was part of the protocol that I read. Okay, so what do we know?
So as you were emphasizing, we need more representation of women in clinical trials, and in this trial, we're doing very well. 6 women.
Ladies are stepping to the front of the line.
So far. Yes, all have had the non-obstructive form of the disease at enrollment. 4 actually, including Julia, had obstructive disease previously and underwent the surgical myectomy. And despite the success of the surgery of relieving the obstruction, they remained symptomatic and at significant risk and chose to participate in this trial.
Again, so Lisa, to point, HCM, as all of us have come to appreciate, is not just obstruction. Obstruction is a big piece of the pie, but myectomy doesn't cure everything all the time. So
I was obstructed as a child, got rid of it on my own through endocarditis. That's a story for another day. And my heart failed before I was 50. And when you look at it, it's just a bundle of scar. So, there's a question out here from earlier on. What is the life expectancy for this disease? And it's a hard question to answer in the general, but you got to look at the specific family trees. And in my family, people were dying, much earlier because of sudden death. Now we have ICDs in everybody, right? And there's heart failure, and I've gotten a transplant. So there's more pathways to live longer, but you need to identify the proper therapies in some families. If a well-managed HCM patient is identified, we can live to normal age of mortality in the United States. However, what is the burden of disease and what else is going on, and how well are we living? And can we live normally if possible? So these are the things that we're trying to evaluate through the work that we've all been doing collectively within science over the past 30 years with the Human Genome Project, understanding precision medicine. So all of these things are kind of coming together in this one therapy and others that are coming as well. So I'll brag one more time and then I'm going to hand it back to Whit. 6 women, 1 man. 6 women. So proud of my ladies today. It takes a lot to step up for a trial like this, and there's a lot involved. And I think our natural caregiver, want to take care of everybody else mentality is we know we got to step up first and do tough things to get answers. So proud of those ladies and that man, and more to come. Anything else on this slide, Whit?
Let's move ahead.
Okay.
So we're very encouraged by the emerging safety profile. Again, more to learn, but so far we have not had unexpected effects of TN-201. And in particular, there's been no heart damage, no evidence of any cardiotoxicity. The immune system does react. There is inflammation, but that has been manageable and treatable with the immunosuppression regimen. Often that is seen in the liver. That's the most common finding in gene therapies, is that the liver has some inflammation. We can tell that through lab tests, but by adjusting immunosuppression, we've been able to control that consistently. And all the first 6 patients have completed the immunosuppression period in a matter of weeks to a few months. The most recently dosed patient is still in progress of turning down the immunosuppression.
So, yeah, one thing I will add, just my 2 cents here, is, our experience has evolved and evolved rapidly in a very positive direction, where now we are much more quicker in our tapering down. So, and I think Whit will talk about it, but higher the dose, yet faster the regression of immunosuppression. So, this is also where we are actively learning and adapting. We are not just sitting around doing the same thing, expecting a different result.
Agreed.
Agreed. And I'm going to answer your question, Helen, at the end. Next slide. Okay. Heart failure symptoms improving. Okay, tell us about.
Yes, I mentioned patients are feeling better. So many folks in your audience are familiar with the New York Heart Association classification of symptoms. That's a simple score from 1 to 4. It's reported by the physician after interviewing the patient, where a class 1 is the best, unlimited activity, no symptoms, limiting activity. Class 4 means unable to do activity and symptoms even at rest. And class 2 is some limitation, and class 3 is a significant limitation, comfortable only at rest. So that's how the scale works. You have to have symptoms to get into the study, and patients were class 2 or 3 at baseline. We have follow-up data for the first 4 patients. And you can see by the week 40 visit, all had improved to class 1. And then 3 patients have passed 1 year at this point, and they're still class 1. And then 2 patients have passed 78 weeks, and they're still class 1. So very encouraging in terms of how patients are feeling after the gene therapy.
It is encouraging. I do add a note of caution on that as an endpoint. We know that New York Heart Association class can bounce around for people with HCM. So I'm going to feel better when I see those NYH1s stay over time. And I wouldn't be surprised if you do see some bumps, and I wouldn't necessarily take it as a loss. We know that when somebody's having an HCM bad day, they can become more symptomatic for short periods of time. What we're trying to do at HCMA is understand NYHA class in real life better. So there's going to be some surveys coming out about that, like how much time are you in an advanced class? So if you're normally asymptomatic, but occasionally get mildly symptomatic or very symptomatic, will therapies help limit the time that you have bad days? We're trying to figure that out at HCMA. Stay tuned for more information on that. And it is the way we're collecting the data is from patient perspective versus clinician perspective. So there's always going to be a little bit of difference there. But you hear me talk in other podcasts about New York Heart Association class a lot. So I just wanted to bring that point clear. This is a lovely indication that we have things moving in a very positive direction, and that's encouraging. But sometimes there can be bounces, and it doesn't necessarily mean failure. It just means
I agree. It's a blunt instrument, and it's not every week is the same for patients. So I, applaud your efforts to understand how it works better. For HCMA members, please fill out the surveys. It really helps us understand what's working and not working in gene therapy. It also helps the people responsible ultimately for approving drugs, like at the FDA, helps them understand what drugs do and how meaningful drug effects are for patients. So it's a great and relatively simple way to help move therapies forward for this disease, those types of patient surveys. So thank you.
Thank you. Okay, next slide.
All right, so in the study, we are looking at pictures of the heart, echocardiograms show the full movies of the heart size and its pump function. In particular, in this disease, the muscle gets big, so the walls are thick, and the overall mass or weight of the heart is increased. On the pictures, we can directly measure the thickness of the wall, and then we use math to calculate the mass of the left ventricle. So in the study, all 4 patients with the longest follow-up have seen improvements in the thickness of the posterior wall of the heart, 9 to 39% improvements. And then 2 of the 4 patients have had already at this point decreases in the overall mass of the ventricle.
I think we need to pause here for a second. Malind, LV mass, does it go down in HCM typically? Why is this kind of a unique finding here?
Yeah, so it does not go down unless, the 2 circumstances where we've seen it go down is if you actually do a myectomy and remove the mass. The other is 3 circumstances. The other is some of these novel medical therapies that are now in the market have shown some level of mass regression. Some of it is due to relief of obstruction. Some of it is due to its direct effect on the sarcomere. And of course, there's the dreaded third scenario where about 3 to 5% patients develop, I don't like to use the term burnt out HCM, but advanced HCM, where it becomes a big baggy heart and the walls thin. So, but this is steps in the right direction because of direct therapy. And we have reached a stage in advanced imaging where we can do these kind of high quality measurements. Remember, this was not biased me looking at my patient and blinking my eye and doing, no, this was measured by a core lab in a blinded manner. So that's why this is absolutely important. That's the purest form of evidence.
Okay, anything else you want to add on this slide? I think we've explained it. Anybody have any questions on that? You're welcome to post your questions at any time. If you're not watching this live on January 23rd at a little after 12 noon Eastern time, you can post your question or email it to us afterwards, and we will field the question to the appropriate person. So how does this work in the heart?
Right,
I'm still mystified by how it actually gets there, even though I've seen it done in imagery a lot of times, but let's explain this process.
Yeah, so this is sort of the science class part of the webinar. Genes are in the nucleus of cells, and they are the instructions for how the body is built and functions. So each gene is encoding a single protein. We have about 20,000 of them, and that means 20,000 proteins working throughout our organs, making our body work. Overall, the instructions for the human body are spelled in about 3 billion letters, interestingly. Next slide.
Okay, next.
So sometimes there's a misspelling, and the gene, it cannot make a functional protein. So as we talked about with MyBPC3, a single letter change can make it so that the protein isn't produced. And that means the heart muscle cells don't function properly, and that leads to disease. And so when it is a loss of function mutation, like the case with MYBPC3, our gene therapy goal is simply to replace that gene. It doesn't require editing. The newer technologies, like people have heard of CRISPR, this is just add a copy of a gene. And to do that, we use AAV, shown on the next slide. So it turns out that viruses throughout history have become very capable at delivering their genes. Of course, we don't want their genes. We remove their genes, and we just use the capsule or the capsid from the virus. That's the AAV viral vector here. It's just a set of proteins. It's like a delivery box. And we put the gene that you want, the MYBPC3 gene, in that box, and then give that as an IV infusion. So it's the blood that's actually delivering the box to the heart. It sends the box throughout the body. But these AAV viral vectors have an address on them, essentially, that delivers them to heart muscle cells. Heart muscle cells recognize them and take them up. And that way, after a single IV infusion to the whole body, we can deliver a gene to the heart muscle cells. On the right, you can see the cell with the blue-purple nucleus. The cell recognizes the package, brings it in to the nucleus, it unwraps the package, the gene comes out, and then the cell can use that gene to make the missing protein.
You make it sound so simple.
Yeah, I'm happy to answer
super
questions.
Complex. Okay. So let's unpack this one a little bit more. So let's talk about heart cells. Excuse me. I'm still getting over this cold from December. Okay. So let's say, Milind, let's start here. How does a human get their heart cells, and how long do they keep their heart cells?
So heart is an end organ. So it is obviously, you're putting me on the spot about embryologic development, and I'm not going to go there. But the most important thing is it's an end organ. And once you have it, you have it. If you lose it, that's when people with a heart attack, you lose heart cells, you'd never regain them back, right? In this situation, there is a level of dysfunctionality by missing proteins. So remember, we are not delivering new heart cells. We are developing triggers that result in the development of protein downstream that would enable these cells to function appropriately. I think I said it right. Yes. So yeah. That's the difference. That's the concept. This is not like injecting stem cells in a knee joint or somewhere else where you are delivering different cells that may multiply and give rise to newer cells. So that is an important distinction to be made.
Absolutely. So it's amazing to me that after 1 week of life, we have all of our heart cells. And of course, infants are teeny. Our hearts grow substantially after that. That is the cells themselves getting bigger. It's not more or new cells. Unfortunately, that's why heart attacks are so devastating. You can't recover the cells if you lose them in a heart attack. But if for gene therapy, it's actually an advantage that heart muscle cells don't divide, because when we deliver the gene, it stays. It doesn't get diluted out in the process of cell division and multiplication. So this therapy has the potential for many, many years of effects.
Exactly. Number one and number two, this was a question that I navigated on more than one occasion, and I'm going to simplify it. So the big concern was, will this result in a fundamental change in my genome that I could pass on to my downstream generation? The answer is clearly no. This is an annuity that you're gonna get, enjoy, and when you pass, it passes with you. So that's an important distinction. A lot of people, everybody's worried about the downstream, and here we have 6 out of the 7 patients are women. So that was something I had to finesse in terms of how I made it simple for people to understand. Correct me, or rather edit as we go. Yeah.
The other thing I want to bring up as we're looking at this mechanism and how it attracts or it gets into the heart muscle, we are not changing the reproductive system. We are not changing the inheritability of these particular mutations. We are changing the amount of protein that exists inside of this person's heart by delivering a protein fix in myosin binding protein C3. Okay. There are some questions, but we're going to hold them. So my peak, delivering DNA and making RNA. So this is the, ladies and gentlemen, this is the one that's kind of important to me. Did the AAV9 get into the muscle, and can we prove that it's in the muscle and that it did something positive? Whit, explain it.
Yeah, so I went through the DNA making protein process. There is an intermediary called RNA, and we measure all three in the heart biopsy samples in this trial. And the DNA is clearly getting delivered to the heart, and it's making RNA, and only the muscle cells can make the RNA. So we know this gene is getting to the heart muscle cells, getting to the nucleus and turning on. And then the overall goal is to replace the protein. And so we're very encouraged to see the results shown on this graph, that the protein levels are increasing. All of the patients in this trial, as you were as well, Lisa, were heterozygous, meaning everyone has 2 copies of the gene. It's only one that's mutated. So you do have some protein, and we're trying to increase that. And so this graph shows the increase in protein over time. The first 2 patients, we didn't have a biopsy before treatment, but we do see levels increasing from early after the treatment, 8 weeks, out to 1 year after the treatment. And then the 3rd and 4th patients are patient 3 and 6 as numbered here. We're comparing from pre-treatment to post-treatment. And at the first dose, that patient had protein increased by 5%. And at the next dose level, that patient had the protein increase by 14%. So encouraging increases in protein. We don't actually know how much protein is required to improve the heart function. This study will tell us that, and we will compare these protein expression data to how the patients are feeling and how the heart looks on the pictures of the heart, and determine. But the early evidence suggests that small amounts of protein expression can improve heart function.
But one thing, Lisa, I mean, I would like to reiterate. I think this is, when I first saw the slides, it made it, as I was driving home that night, it made it all worth its while, clearly. But, the reality is the primary focus of this particular study is, can we do it? Can we do it safely? Can we deliver the goods, the payload, to where it's supposed to? And when the payload is delivered, does it turn into the real goods that we think it will turn into? The answer is yes, 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 yes to everything, right? And then at some point of time, everybody has an inflection point as to how much protein they need. I don't think any one of us knows that you need X% or Y%. Anybody who tells you, they are also guessing.
I think this is a really important point for any patient or family member who's considering this trial. I think this is the big ta-da, really. How much protein does it take to improve functioning of the heart for the long term? Do we have to add 1%, 8%, 9%, 50%? Like, where is the number? And considering, when you really get right down to it, it's kind of amazing how well the HCM heart works as is, considering it is deficient of this protein that is so important to the motor running. So if we're doing okay, because we're living and we're functioning, is a small amount of protein enough to give us the amount of energy that our heart needs to function properly and in the proper way? So this is the money slide to me. Like, are you proving it? So we know that the protein's getting into the heart, but we don't know how much you really need, and we don't know how long it's going to last. Those are the 2 questions, and that's why we do clinical trials. And that's why we do studies, because we don't know. But some people are going to help us figure it out. Okay. Anything else
I
on
agree.
this
That's
slide?
exactly the hypothesis that we're testing. The fact that this is a slowly progressive disease, often over the course of decades, could suggest that proteins have almost enough protein, and a bit more will make a big difference.
And Lisa, I mean, this HCM crowd probably will understand. I'll I'll put it in a slightly different way. Say you have obstructive HCM. We have patients who get so short of breath with a gradient of 45 millimeters of mercury. And there are people who are hauling a deer after a Thanksgiving deer trip. I'm giving an exact patient with a gradient of 120 millimeters.
I know the story. Yep.
Yeah, exactly. So this is not a one size fits all. And the non-negotiable here is it safe? The second non-negotiable is it going to where it's supposed to be? The third non-negotiable is it's getting out of the liver, out of Dodge without creating any collateral damage. I mean, these are some of the 2-3 things beyond which I think time will tell who needs how much. And, look, I may need X% protein increase, Whit may need Y% protein increase, and you may need Z% protein increase. That number may be different for all three of us.
And over more time, I think we'll be able to refine, but you're going to need bigger numbers and larger populations to do that in. Okay, next slide.
So speaking of, we are continuing to enroll this trial. It is focused on the United States and these 5 sites in the United States. So it does involve travel for patients. That we discussed that earlier, but hopefully we are we're spread around the United States. So hopefully the travel is not too onerous. We are only accepting adults at this point. You have to have this particular gene mutation and have a hypertrophic cardiomyopathy with symptoms. And then, Lisa, you want to make sure we covered this point. A small percentage of the population, maybe 1 in 5 folks, will have their immune system has already seen this virus, the AAV9, and they have antibodies already made that would prevent the gene therapy from working. So those patients, unfortunately, won't be eligible for this clinical trial.
So, Lisa, I'll tell you one thing. When we were doing this earlier phase study, honestly, I was expecting a lot more people who would not qualify. I mean, just the pragmatic thought process occasionally that as exuberant I can be, that was the pragmatism on my, but I was pleasantly surprised that number is not high. And like Whit says, so we can help a lot more patients than I first thought we could, which is good.
And I'm happy to hear that as well. The other part of this, and I'm going to pull the slide down for a minute just for a conversation here. If somebody joins the trial and they're an early adopter, and we find out that they need a higher dose, a different dose, there's not another bite at the apple on this one because they've developed an immunity, correct?
Correct. For this trial, there is not a second dose or an opportunity to go back. The field is working on this. We did mention that one advantage of gene therapy for the heart is the heart cells don't divide. It doesn't get diluted. It could last for many, many years. Other organs like the liver, cells do turn over. So for hemophilia, for example, that's something where the effect could wear off. So the field is working on redosing and how to achieve that. So that may become possible in the future, but not today and not in the context of this trial.
Okay, we have some questions coming in. Helen, I'm saving your question for last. Okay, I'm going to pop them up on the screen. Malik, are there any dosed individuals physically active in sports, and will they be able to stop taking their medication if their heart becomes more normal after they receive therapy? These are very futuristic questions, Malik. I think I'm going to start with Melinda on this one.
So every one of my patients is, for the most part, back to doing what they want to do in terms of their life. The answer, are they professional athletes? No. As I alluded to earlier in the podcast, Julia, who you met, yes, I had PVCs when I heard that she wanted to go snowboarding. So, Is that a sport? Yes, I would think so. I would not want to do. I don't do snowboarding, for example. I mean, so
Again,
everybody's doing what their quality of life is. So, and the second question, would they be able to get off of guideline medical therapy for, look, realistically, non-obstructive HCM, there is no guideline directed medical therapy. So whatever we are doing is anecdotal and experience, etc. So, I don't know the answer. I mean, it may come to a state of affairs in the future where we may be able to roll back some of the medications from them if they continue to do well.
I think
and prevent future as well. So right now it's normal for development of a drug. We are enrolling patients that are severely affected by the disease already, but gene therapy is well suited to prevent disease. And so that is a direction that we'll move in the future.
So we have a question on some of the parameters that you're measuring. Are you looking at fibrosis, arrhythmia risk? What are some of the variables that you're hoping to learn more about?
Yeah, so we do take images of the heart. We are following that closely. And then we do monitor for arrhythmias as well. The patients in the study have ICDs. We've seen no evidence of increasing arrhythmia after the therapy. Serious arrhythmias are very concerning, but they're also very rare in this disease. So it's not something we can look for improvement easily, but we'll need a much larger numbers of patients with more years of follow-up to make any conclusions about that.
So in terms of Manuel, your question about fibrosis, at least the first group of patients, had a defibrillator as an entry criteria. So doing cardiac MRI, which is the gold standard way of measuring, assessing fibrosis, we did not look for that because you've got to balance risk versus benefits and safety, etc. But there may be a future state where we may look into these things. But like with Dr. Tingley said, arrhythmia we have not observed, and we monitor. At least the first group, they stay in the hospital for 7 days and 7 nights. So basically, they are monitored very thoroughly, and we have not seen anything out of the ordinary.
I think that's a great point. We have a very detailed question here. So I'm going to start the question by saying we don't have an exact answer for you, but we can talk about this more hypothetically. So we're targeting MYBPC3 here. Would a similar potential be available for a TNNI3 HCM related? They are functionally different mutations. We know that. So I'm going to kind of homogenize this question. Can you discuss gain of function mutations versus loss of function mutations? And then we can start getting into some ideas about other mutations, because there are some other gene therapies being developed by other companies that are looking at troponin, their TNNI. So there's other pathways, but can you talk about gain of function and loss of function and what genes might be actionable through this and what might need something like an editing?
You're exactly right that's what determines whether gene replacement therapy is appropriate or editing is required, is whether the gene mutation is a loss of function, you just need to replace it, or if it's a gain of function or a poison peptide where you need to edit it. So in that latter case, gain of function poison peptide, it is making protein, but that protein is wrong and it's disrupting the cell. So it's poisoning the cell, a poison peptide. So that's when you need to edit it. You need to get rid of it, silence it, to turn it off, or edit it back so that it's spelled correctly and functioning correctly. But if that poison protein is circulating around the cell, gene replacement won't work. So I think there are many mutations in troponin I that replacement will work. But it depends on the mutation itself and how it works, and not on the gene.
So I think the easiest way in layman's term to think about this is, what is my genetic mutation? Is the heart not working because I'm not giving it enough of something, or do I have too much of something? If I don't have enough, this type of an approach may be beneficial, but we're still at the early days of learning, and there's 7 people dosed for this. We've got some in Danon, we have some in elsewhere, but we don't know a lot yet. And gene editing is a whole different process, which we will talk more about later in the year, but that's for gain of function. You've got something in there that doesn't belong, and we need to get it out. And that's a different process, and that's not what we're talking about today. We're talking about adding protein in and adding function. I hope that's clear for everybody. We have a good question here about men and women measurements and treatment. I will start and then I'll hand it to Malind. So we know that men and women both have HCM, and it's pretty equal in who has it. Men tend to get diagnosed a little bit earlier. Women tend to get diagnosed later, and they're a little sicker when they get diagnosed on average. Obviously, there's people who get diagnosed young with disease, and we're managing throughout life. And the symptoms are pretty much the same. Like in most diseases, women, their symptoms do manifest differently than men, and most of the published literature is about men's symptoms, specifically chest pain for heart issues. Women may get jaw pain or back pain. Men get chest pain. So there are some differences in symptoms, and we're getting better at identifying those. Malind, what else do we need to know about men and women, and what is the normal wall measurement?
Yeah, and also often, women tend to present a little bit later. Women tend to sort of, or rather in the past, and this is rapidly evolving and changing for the good, where, women are now getting increasingly more recognized if they have a symptom in the correct diagnostic format, as opposed to in the past, oh, this is not that. Now, your specific question about measurements, yes, it is known that men have higher mass, and wall thickness measurements may be slightly different. But in the context of what we are talking about, you, the patient, are your own control. So we have your echo at baseline, and you have your serial echo or MRI or what have you during follow-up. So all the mass regression business we are talking about is not comparing to anybody else. So I think, imaging technology is advanced enough and sensitive enough to be able to detect such subtle changes. Now, and in terms of treatment, look, clinically, gene therapy is still investigational, right? So clinically available things that we have, newer drugs, surgical myectomy, etc. In good hands, surgery is safe no matter what the sex is. And I have actually published a sub-study from the VALOR study, which has shown that mavacamten, one of the CMIs in the market, mavacamten has an equal effect in both sexes. So I have no reason to believe that an appropriately diagnosed and well characterized from an imaging perspective patient, there should be any difference between men or women.
I will add one item to
gene
that.
Therapy we fully expect will work the same in women and men, because the women are stepping up and enrolling will learn first in women.
Which I kind of like that, but that's a whole other story. I will say that there is a new tool that's being evaluated, and it's in research right now. So it's not for clinical utilization, but we've been kind of playing with it with the researchers on the back end. And this is a standardized tool to take body size, gender, and age into consideration when estimating maximal wall thickness. So we know the diagnostic criteria for HCM has been a wall measurement of 1.5 or greater. And then we put an asterisk on that. Well, if you carry a gene and you're a woman and it's 13 or greater, that's probably still diagnostic. So we're getting better at realizing that a 6'6" guy and a 4'11" women probably shouldn't have the same wall measurements in their heart. And now we're refining those numbers more. So we're gaining knowledge. Thank you all for sharing in registries and research projects so we can understand better, but it's coming along and more to come. And my great, have nothing to do with this topic, but I want to know how hormones impact women with HCM, because there's something there, people. There's something there. I don't know what it is, but there's something there. Okay, we have a couple of more questions. I know we're going a little bit over time here, but these are great questions. Is University of Iowa one of the sites? No, it is not one of the sites at this time. There are most of the sites seem to be on the border of the country at this moment. They're up north, they're down south, they're out west, and in the east. Nothing in the center yet. Stay tuned for more as that comes up. Brian, I don't understand your question. So reverse split soon, I fear. If you want to explain that one a little bit greater, I'm not sure where you're coming from, but I'm sure you can clarify it if you would like. Helen would like to know, do you accept homogeneous patients of MYBPC3? Whit, you want to talk about that?
Yeah, so homozygotes means both copies are have lost function. That's very rare. It does happen. All of the patients that we are aware of needed a heart transplant in the first year of life if they have 2 loss of function mutations. We do, they're not eligible for this trial, but we do on our website have a compassionate use program where that child's physician could apply to Tenaya and be evaluated to get the drug on a compassionate use basis.
Yeah, and Helen, so that's a very insightful question. But like Dr. Tingley said, these patients, they are not gonna get past childhood without something being done for the most part.
So a double hit in a child is catastrophic. And that is why the compassionate use was brought to bear. Has anybody utilized the compassionate use yet? Or I don't know if you're able to say.
Yeah, we are actively evaluating patients now. So applications are being reviewed as we speak.
Okay. So if anybody needs any assistance with that, we can make sure you get in touch with the right people. You can reach out to Tenaya directly. But if you have any questions, please do feel free to call the office and we can walk through it. This particular one is 20 years old, so he's doing well. So it's that one with one. So
that's terrific.
That's awesome. Okay, another question. It seems like there was a blue circle in the middle. Is there something in the center?
Those are the sites that we have.
Yeah, no.
Mayo.
Mayo?
Mayo.
Okay. Sorry, Mayo. Missed you on the map. Okay, now this one's a little off topic. Can you please touch on the side effect management of the new standardized regimens as requested by the FDA? I'm not exactly sure what you're going at, Matt. You might be talking about myosin inhibitors. Give us a little more context here, or what you want to try to
I think it's probably, Matt, you're asking about the immunosuppression regimen.
Oh, yes.
So we do partner with the FDA. The FDA has, probably more knowledge about gene therapy and safety monitoring and management of any institution in the world. They, of course, review our protocols. We had a close conversation with them based on our data a few months ago, and we made some minor tweaks to our protocol with their input. But we continue to use the same medications we've always used, prednisone and sirolimus. And we have been able to adjust the timing and dosage such that we've been able to use lower doses overall. I think Dr. Desai presented his data and the details behind it at the American Heart Association meeting in November, and it was very well received. As he said, we are learning as we go forward. That's the purpose of early clinical trials and trying to improve things for patients as we go. So it was, in terms of the recent adjustments, it was great to have the discussion with the FDA and basically an endorsement of the prednisone and sirolimus regimen that we had been using already.
I want to pause on that one for a minute because there's some pieces of this system that are not fully transparent to patients. And it is the relationship with the FDA. And it is the fact that the FDA is working with multiple companies doing trials that are similar. They're learning from the global experience And what we learned for one trial in one company, if it is a safety signal, they're going to take those best practices and make sure that the rest of the people in the field understand what's happened in somebody else's trial and how it might impact theirs so that we can make safer trials. And there's in all likelihood, within this particular trial or another gene trial, there could be stops put on things because they have to align the protocols and they have to do safety checks. It's not a bad thing. It's part of the process of moving forward. I've been following the Danon disease LAMP2 project from Rocket Pharmaceutical. We helped launch that originally because a lot of people think HCM and Danon are the same thing. They're different. And we now have experience. I think they've dosed 12 or 13 in their trial. And we've learned a lot through that. That helps inform MYBPC3, which help inform another, which will help inform another. So it is this process of learning together and growing together. I'm going to bring up
for safety, obviously, is the top priority. It's our top priority at Tenaya. In addition to FDA input, we have gotten input from experts in the field, as well as other companies developing gene therapies with further along and have more experience than us. But that's all redundant with, Dr. Desai, and he mentioned all the people on his team that are ensuring safety as well. So a lot of redundancy. Safety is the top priority.
I think, one thing I will say, you, the PI, or me, the PI, has to be committed to this. This cannot be, my people will take care of your people who will take care of your people. I have to be engaged. I have been engaged every step of the way. And, the institution leadership needs to commit to innovation and supporting you. You cannot, look, a lot of times what ends, you've known me for a while, Lisa. I am an incessant planner. Okay, I think of a lot of contingencies, logistics. I put everything in my life. The way I approach life and medicine is supply chain logistics. You break everything into individual parts.
Yep.
Think about all the contingencies, how things can go sideways, plan for them, and then move to the next step. I think that philosophy has worked very well for me.
And this is one of the reasons we're going to the FDA with an externally led patient-focused drug development meeting to discuss specifically our community's burden of disease. Let's face it, it is not fun to be limited by HCM when you're in your teens, your 20s, your 30s, your 40s, your 50s, and it's constantly there. If there was a way that we could make our hearts work more normally, that would be fantastic. And this is the goal, but we have to get there safely, scientifically, sustainably. Like, we have to build a whole system to deliver a different kind of medicine, right? There aren't gene therapy clinics in your local hospital yet. And there might be at some point. It just may be a different type of medicine, but we're developing it together, guys. Patient, industry, clinician, regulators. We are in this together. This is teamwork at the highest level, and it's hard work. So now I'm going to bring up the question that I hate and I normally ignore, but I'm going to bring it up. Lisa, if you could have the option of gene therapy rather than transplant, what would you have chosen? I'm going to tell you the exact truth. You may not like the answer or understand it because it's true. I didn't have the option because it wasn't available to me at the time that I would have needed it. By the time my heart got to the point that it wasn't viable for much longer, I had to make a choice based on the facts in front of me at the time. I never had the opportunity to evaluate a gene therapy in real time. I also never had the opportunity to do pre-implantation genetic diagnostics to stop my daughter from having HCM because it wasn't available for me. Would I do PGD today to stop my daughter from having HCM? Absolutely, hands down, I would make that decision today. Would I have gene therapy today if it was an option? Probably not, but not for the reasons you might think. I don't
And-
want to go first on this one. As an HCM patient and as a leader in the field, I wouldn't go first on this one for a lot of reasons that are me reasons. And that me includes my job, my family, and my disease state. So for me, I don't know that that would have been an option. For a member of my family, I highly encourage them to have conversations with their care team and investigate every clinical trial in the space and find out what works for them at that moment in time and with what's on the horizon for availability. I think Julia said it best earlier. She looked at her family, her disease trajectory, how she was feeling, and what the arc of the discovery was going to be and when she would be able to get it clinically versus during a trial. So she made decisions based on the reality of the moment. So I would base all of my decisions on the reality of the moment in my life. And honestly, I would do PGD hands down, absolutely. This clinical trial for me, no. But others, they should talk about it. And if it's right for them, they should do it. Ellen, I appreciate you asking the question. It's a tricky one, and I hope I hope you guys understand my answer. What do you think?
Lisa, can I chime in 1 second?
Absolutely.
One of the things with any therapy, we have to also realize and balance, the return on investment. Okay, your heart is your investment. Therapy is your investment. One of the things that I have struggled with, and and this is what I look for in patients that I'm thinking about, is when are you too far out where the horse has proverbially left the barn? Okay,
Yeah.
we want to find that sweet spot where there is chance for meaningful improvement. You do not want therapy. Look, there is failure of therapy. There is therapy that does not work. But failure is side effects, all those things. We all know that. But the therapy doesn't work. Did it not work because it is not good enough? Or did it not work because you, the patient, or me, the patient, is so far away that there's no chance for meaningful return? So I think that's also important, which is where, Julia's risk-benefit analysis, and, it's not just Julia. I was looking at, I had to sign off on that infusion, right? Julia signed off on the IRB. I signed off on the infusion and every other prescription afterwards. So that was the calculated return on investment conversation I had in my mind. Again, I've told you, Julia is not that much older than my daughter. So,
She's the exact age as my daughter.
Yeah. So that's a big burden. That's a big burden. So we, but that is something very important. And Lisa's story applies to Lisa.
Right.
There's only one Lisa. We all know that. So,
we are all an N of one, and we all have our life experience. And I go back to my favorite quote from my favorite poem. Tell me what it is you plan to do with your one wild and precious life. Not mine, it's yours. You get to decide. Okay, there's another comment here. I'm not going to get into it in detail, Matt, but I do want to acknowledge that our viewership on Tales from the Heart has changed and has grown. And there are members of the investor community who pop in here too and ask questions because they are part of the ecosystem. And they're questioning, some stock prices and things like that. I'm not going to get into that here. We're a patient advocacy organization, and I'm going to stick to patient safety and the science. And I'm going to let the street fight it out amongst themselves because I got enough battles to take on, and you guys can work on the finance side of it. So
one thing, Lisa, I forgot. I want, with regards to your transplant, and the gene therapy does not preclude a future transplant. Make it very clear. Yes, that for anybody on the audience who has any misconception, I cannot be crystal clear about that.
Yeah, that's a very good point. Thanks for bringing it up, Melinda. I didn't go that far with the answer, but we don't know what the future holds for anybody. And transplant may be another option for people. And I've been talking to some pretty interesting people lately in that space, and new science that's coming, and xenotransplants and all kinds of crazy stuff that's coming down the pike. But we don't move any science forward without a couple of core things: the money to do the work properly and safely, the clinicians with the clinical understanding of disease state to help the pharmaceutical companies or drug development companies develop really good targeted therapies for us, and the patients getting involved in doing the trials. It takes us all, and we're all in this together to improve the lives of people everywhere and make sure that the therapies that we're designing today get into people in the future if they're appropriate and safe. So, Wit and the entire team at Tenaya, thanks for being thought leaders. Thanks for being brave to go into a place that doesn't have very finite answers at this time, and doing good scientific research to ensure that we're getting good answers to tough questions. Melinda, you step forward, and I got to tell you, I was a little surprised. I'm like, Melinda's going to dose the first genetic therapy? Okay. Didn't see that one coming, but you stepped up, and that took some bravery on your part too. So I appreciate you stepping up. And if you want to comment on that experience, I'll let that be your final words.
So thank you. I always like to under promise and over deliver. I am kind of Scandinavian in my approach, like that.
I'm Scandinavian in all approaches. Anyway.
Yes. But, look, I will never forget a comment one of my colleagues made after the fact in a meeting. Their comment was, their institution would not have supported this because they would have been afraid of a potential headline if something went sideways.
Wrong, yeah.
Okay. A prominent institution, and somebody we all know, made that statement to me. To me, that is not an option. Okay. For me, if I believe in science, if I believe in the process, if I believe in myself and my team, and if I have the backing of my leadership, in this case, Cleveland Clinic, I'm going to go for it. If you ask me, would I do this again? You're darn right. I would do this again. Absolutely. 100%, because this is about moving the field forward. Okay. I mean, imagine Neil Armstrong, I'm better off hanging out in the Johnson Kennedy Center at Houston. Why would I want to go to the moon? Imagine where we would be, right? So no, this is not an option. But you jump into a pool without planning, without the logistics of all these being thought out and the backup and this and that. That's not right either. And so I would do this again in a heartbeat. No question about it.
I am glad to hear that. Whit, I thank you so much for joining us today and explaining the trial again in a different context and in a different way. We got our brick walls going. That was always good coordination, and we had them in New Orleans, but with bad sound. So now we have the whole story told in a neat way. And if anybody's interested in learning more, please go visit the Tenaya website or call the office, and we can help align you. We're going to keep talking about this.
For having me, and we've told the whole story as it is today, but we have more data coming out, and so we look forward to more updates throughout 2026.
More updates, and you're all going to see Melinda join me in another week where we're going to talk about some recent publications he has. And just for some programming notes here at the HCMA, we are building out our new podcast schedule for 2026, which will include a couple of new elements, including our series called Deconstructing Healthcare. And we are breaking down healthcare law in the United States to understand what the foundational basis of our system is, where things are going a little awry, and where we may all be able to step in, use our voice, and make some positive change. So join me in the next couple of weeks for episodes on deconstructing healthcare, where I will be joined by a lot of people, including Jan Berger, a member of our board and a former chief medical officer for a major insurance carrier. So she knows the other side of the story. So we're going to build that story together. In a couple of weeks, we're going to have our first session on pediatric HCM in the podcast. So look forward to that as a series. We're going to continue with our expert series, our Share Your Stories. And the other new element is recent articles of interest. We're going to be scaling all of the publications every week and inviting one or two authors, or maybe 2 authors, 3 authors per paper, to come and discuss in a 30-minute format the new paper and how it impacts HCM. So we're going to be doing a lot more podcasts, and this podcast makes it number 201. And it's season 6. So we're going to keep going and keep having good conversations. You asking questions during these sessions brings them to life, and make sure that other people understand as well. Because if you're thinking it, they're thinking it. And I thank our participants for taking your questions and answering them so nicely. And please come in and join us for another event next week. And then you're going to see a lot of us in February because it's Heart Month. And if you want one of these super cool box kits to have a party in your office, I should have really come up with these for sponsors, and we're going to do those next year. Demi, you want to bring the kit page up? I'm going to bring it up to screen. So herein ends our podcast on Tenaya and gene therapy, and I'm going to go back to some core issues for us. If you want a frame on your photo for your social media, email support@4hcm.org a photo. We'll send it back to you in a frame because Facebook won't let you do that anymore. If you want a poster so you can hang it up at your workplace or your church or your sports event or your school, and you want to talk about HCM, we have about 30 kits that we can send out, little tabletops to know HCM and some scan codes, new bracelets, new materials. We'll send them out to your home, your office, wherever you want to show this. Got 30. Email support@4hcm.org, and we can get you a kit out in the mail by next week. I don't think they're going to last very long, people, so get them while they're here. Next year, we'll do more of them, I promise. Okay. Thank you all for joining us. Julia, thank you for joining us in segment 1 and sharing your story. You're inspiring so many people. Girl power, sending you lots of love and appreciation for your willingness to step up. Whit, thanks for everything. Malin, thanks. Thanks for joining us on Tales from the Heart. Have a great weekend, and watch out for the snow, everybody.